Hello, everybody, and thank you for joining me today. Before I start, I want to say a sincere thank you to Doug Reynolds and to the entire, and Pam Devine and the entire board of SHMP. Um, I'm very excited about things to come in the low-carb space, and I'm honored and happy to present here today and to be a part of this amazing community. Today, I'm going to be talking on a topic very near and dear to me. This will be a clinical presentation discussing two case series that we've published here in this office and two more yet to come. And so you'll be getting a sneak peek. The title is Dismantling Dogma, and it's a call for a critical need for more flexibility in clinical guidelines. So I have some relevant disclosures to make here, and I'm going to make them now. Personally, I've benefited from a low carbohydrate diet in that I failed Weight Watchers and low-fat diets, and I lost 150 pounds using low carbohydrate and intermittent fasting approaches. So I'm very fond of metabolic health, and that's a disclosure that I want you to know. And in terms of personal financial disclosures, my practice is known for low carb and intermittent fasting approaches, and certainly I'm one of the co-hosts of the Low Carb MD podcast, but I'll say that we don't take any sponsorship whatsoever. And my wife, I have to note, is the CEO and the founder of Rosette's Cookies and Rosette's Mixes. And so even though I have taken no money and she has not taken any salary yet from this company, we have to disclose this. I have to disclose that I'm related to her. She's my wife. So those are my disclosures. Okay, and if you don't know anything about me, I was once obese, pre-diabetic, hypertensive, with sleep apnea, and then I found my way. After a lifetime of obesity, I went to the medical literature looking for evidence, and I found the evidence, and I was surprised by what I found because it was exactly the opposite from what we were taught. And in fact, that is going to be the theme of this presentation. What the guidelines say is not always what's accurate. And you will see a pattern and which is my passion, which will be dismantling the parts of these guidelines that are false and the parts of these guidelines that need more flexibility. So what are the objectives of this presentation? Our objectives are to review clinical guidelines as it pertains to therapeutic carbohydrate restriction, most notably, the American Dietetics Association guidelines on disordered eating, the NLA and the ACC guidelines on severe hypertriglyceridemia, the ADA guidelines on medical nutrition therapy for type 2 diabetes, and the AHA-ACC lipid guidelines. And we are going to point out areas that we believe need flexibility in these guidelines as it pertains to metabolic health. So let's see, what do the guidelines say about eating disorders? Well, if you look at the American Dietetic Association, their position statement on nutritional interventions, and you have to understand, this is a guideline that encompasses anorexia, it encompasses bulimia, and it encompasses binge eating. And whether they want to acknowledge it or not, it does also encompass food addiction. But I want to point out some of the statements you can find from the dietetics guidelines. So individuals may experience disordered eating, okay, that extends along a range from food restriction to partial conditions to diagnose eating disorders. And why am I bringing up this quote here from the guidelines? Because here they are hinting at that food restriction is on the spectrum of an eating disorder. And as you know, on a low carbohydrate diet, we certainly restrict certain foods. So I'd like to see if this hypothesis holds true in the literature. I'll fast forward and let you know, hint, hint, it doesn't. Okay, and here you go Dieting, another statement from these guidelines, dieting typically precedes the full-blown eating disorder. And so I've been on a low-carb diet for 7 years, and I'm waiting for my eating disorder. And so, the question here is these dietitians, they're very concerned about a wide variety of eating disorders, including anorexia and including binge eating, which may sit on the opposite spectrum. So when it comes to restrictive eating, the question is does it cause an eating disorder? And my contention will be it does not. And if you look at here, potential signs of an eating disorder, well, let's see how many of these apply to a ketogenic diet. Certainly we have, a potentially abnormal electrolytes. Certainly, you may be intermittent fasting, and you may have a large one meal a day. So some of these things, and anxiety around avoiding certain foods, maybe you have compulsions to sugar and you want to avoid them. These are things that are very common and very normal for people in a low carbohydrate diet to experience. So are these actually risk factors and potential signs of an eating disorder? Possibly. The ones I think that I most agree with here is these intense fears of weight gain and preoccupations and poor body image. I think these are the critical things to pay attention to, and some of these others probably not so much, and I think the literature bears that out. Let's review some of the data, okay? Now, these guidelines are written by consensus statement. Well, let's review some of the data that's come out since those 2012 guidelines. In this paper here by Stice, it's very interesting. They look to see in general what is strongly associated with the development of an eating disorder. And what they found was while dieting in general had a mild association, it was really the thin idealization and the body image, the poor body image that more strongly predicted eating disorders. Not, the dieting was a very minor association. Okay, here's a study from Deleuze and Gibson and Hay, which basically shown that severe energy restriction, right, in an acute setting did not induce or increase binge eating. So this was a systemic review on various diets that reduce energy, and it didn't induce binge eating. So at least in the acute setting, it doesn't seem that dieting actually causes an eating disorder. And certainly, if there was an association with dieting and an eating disorder, it's a very minor association. The major one is that the weight stigma and the body image. And well, here's the thing. There are actually interventions that are restrictive that actually lead to improved outcomes when it comes to eating disorders, right? So they're actually able to prevent eating disorders in eating disorder prevention programs, particularly in high-risk populations, mainly adolescent and college-aged girls. But that those genotypes are expanding, and those genes, we're basically seeing this happen more and more in men now. But these risk prevention programs, which emphasize a healthy diet. It's certainly that's restrictive to some extent, that really emphasize whole food snacking. Now, while I agree with these messages, certainly they're restrictive, and in fact, these restrictions of eating whole and real foods and a healthy diet, it actually, combined with other lifestyle factors and other psychosocial support, these improved outcomes and prevented eating disorders. So I don't believe that restrictive dieting per se or dieting per se actually exacerbates eating disorders, when we've shown that programs like Healthy Weight actually prevent eating disorders, and those encourage whole food eating and healthy diets, which could be argued are a restriction. So this is another study from 2012 that showed that the Healthy Weight program, which I just alluded to, although they do recommend a healthy, sensible diet, really what we think is driving this ability to prevent eating disorders is the improving self-confidence, reducing that thin idealization, and reducing these body image issues that plague this demographic. So look, the bottom line is the current guidelines say that, restrictive eating could cause an eating disorder, and that, restrictive dieting lays on the spectrum of eating disorders. So in our case series that we published last year, with Dr. Sethi DeLay and Dr. Westman, we actually showed 3 patients with significant improvement in binge eating symptoms and food addiction symptoms using a ketogenic diet, and 2 out of these 3 cases also use intermittent fasting. And so I want to just highlight that here. If you look, the interventions were a range of ages. 2 of those patients, as I mentioned, used restrictive eating, time restriction, and all of them had comorbid binge eating and food addiction symptoms. Their average BMI was 43. And what happened? After about 7 months, what we saw was basically there was no safety or adverse events reported. Nobody said that they developed worsening of their binge eating symptoms. In fact, just the opposite. These patients lost 10 to 24% of their body weight, and their symptoms of food addiction and binge eating significantly decreased. And that's highlighted here. This is a big table. I just want you to pay attention to something here real quick. If you look, just imagine these are lives here where at baseline they're saying they're binging on food several times a day and several times per week, and then reporting basically complete resolution even after 6 to 7 months, 9 to 13 months, and after 17 months. Their amount of binge eating has significantly decreased, and we quantified this in a number of the cases with the binge eating scale. We showed a 9-point reduction, a 6-point reduction, a 4-point reduction in the Yale Food Addiction Scale. And this is a big change. This is somebody who feels guilty about the way they eat, overeating, several times a week, to essentially having, 1 or 2 episodes a month and fairly controlled. So this was a huge impact. And what the goal of this case series was to show that you can use a restrictive diet and you can even use fasting, and it may help food addiction symptoms. There could be a central mechanism to the ketosis that helps binge eating, that reduces appetite. So that was the hypothesis of this case series. Certainly we need more studies, but our first goal was to dismantle this idea that restrictive dieting cannot be used in an eating disorder. And basically our conclusion here is that more flexibility is needed. In this case series, we basically showed the feasibility of using a ketogenic diet with or without intermittent fasting, and it reduced self-reported binge eating symptoms. So let's go to the guideline checklist so far. This is my interim goal in my next several years. I want to attack the guidelines on eating disorders and show them that a ketogenic diet can be consistent and should be allowable in these guidelines. There should be flexibility to include them. And certainly I'm going to show you now how a ketogenic diet should be included in the guidelines for severe hypertriglyceridemia. And then we will discuss the ADA guidelines and lipid management guidelines. So lowering triglycerides, what do the guidelines say? Okay, if you look at the AHA and the ACC, if you have triglycerides, this is basically fat in the blood. If the triglyceride levels are very high, the ACC and the AHA now say that you should do a very low fat diet, and that's the treatment. And in fact, the AHA says that a high fat diet, the NLA says a high fat diet is contraindicated. If you look at here, they say that you should implement a very low fat diet. And in fact, it's contraindicated to use a very low carbohydrate diet in severe hypertriglyceridemia. And they list potential of harm in their grade 3 evidence for contraindicating a low carbohydrate diet. And there's some reason to it. They're concerned about familial issues dealing with blood fats and hyperchylomicronemia, and they're concerned that maybe if the fat levels really go high that you may develop pancreatitis. So legitimate concerns, but let's review some data. We've known since the 1960s that if you reduce your carbohydrates, that we can bring triglycerides from the 800s all the way down to the 200 range. And if you reintroduce carbohydrates, that those triglycerides go back up. And certainly we've seen this. This is from a journal from 1968. And let's review some more recent data from Volek and Finney. They've shown when you compare low carb and low fat diets that low carbohydrate diets reduce triglycerides, fasting triglycerides, and triglycerides after meals. That's because the fat oxidation increases, the ability to use these fats for fuels increases. And you can see that fairly consistently on meta-analyses, and that triglycerides are lowered and HDL is increased on a very low carbohydrate diet versus a low fat diet. And certainly Yancey and Nunes did a meta-analysis pretty much showing that a low carbohydrate diet consistently lowers triglycerides more so than a low fat diet. And we've even had case-controlled studies that have, calorie-controlled studies showing that it is not the calories, but it actually is the carbohydrate reduction that causes a decrease in triglycerides. So with all this data in mind, we wanted to attack these guidelines that unfairly demonize low carbohydrate approaches. We published a case series in Current Opinions in Endocrinology, basically highlighting severe hypertriglyceridemia and the use of intermittent fasting and a low carbohydrate diet. And wouldn't you know, we took triglycerides of over 1,000 and around 1,000, and within weeks the triglycerides were under 200 and sustained under 200. So, and this is a case series of 2 patients from our practice. And so what have we done here? Should every patient with severe hypertriglyceridemia do a high fat, low carbohydrate diet? Not necessarily, but the guidelines need to include this. With a minimal amount of weight loss, here we're showing a 1,000 point drop in triglycerides. And it's not like this data is new, although it is remarkable data that we saw in our practice, we observed in our practice, and we published calling out the NLA and saying that you need to reevaluate this. Although we did that and it was widely received, it was spread all throughout social media, this data has been there since 1968. Okay, so let's go back. So far from our practice here in New York, in Japan, we have tackled the eating disorder guidelines, calling into question, basically calling into question this restriction on this claim that restrictive dieting causes eating disorders. We also tackled the NLA, the AHA, and the ACC guidelines on severe hypertriglyceridemia. We showed a case, literally of thousands, triglyceride levels of thousands coming to under 200 into the normal range. So we showed binge eating symptoms improving on a ketogenic and low carbohydrate approach. We showed severe hypertriglyceridemia, and these are published in the medical literature. You can go read those journal articles and read about what we did. And the next steps for us are to tackle the American Diabetes Associations and the ACC-AHA guidelines on lipid management. And I'm going to give you a little flavor of what that data is going to look like. And again, this is unpublished. This is not peer-reviewed yet. The 2 case series I've presented so far, they've been peer-reviewed and they've been published, but this is unpublished data, so keep that in mind. So glycemia, let's see what the guidelines say from the ADA. This is the ADA guidelines. Basically, the ADA guidelines, this is a literal quote from them saying that evidence suggests that there's not an ideal percentage of calories from carbohydrates and protein and fat for all people. It sounds like a lot of kumbaya nonsense to me. And then they go on to say that if you have diabetes, you should eat more beans, peas, lentils, fruits, and whole intact grains, right? So these are the foods you should eat to lower your blood sugar. This is straight from the ADA guidelines, okay? And they say that that weight loss is the most critical part of managing type 2 diabetes, right? So this is actually what the ADA guidelines say. A lot of people quote the guidelines and saying they're now favorable in 2019 of carbohydrate reduction. But if you read the entire guidelines, it's like a backhanded compliment. They really are, talking out of both sides of their mouth. So let's review some data. Here is a study, I'm going to bring it to your attention, that basically it was a calorie-controlled study showing that decreased carbohydrates, independent of weight loss and independent of caloric intake, was basically decreased glycemia and glycemic variability. And this is important because in this study, they took patients with diabetes and said, we're not going to change the amount of calories you're eating, we're just going to change the amount of carbohydrates, and we don't want you to lose weight. And what happened was that the glycemia improved. Who would have thought if you lower the carbs that you're going to improve the glycemia, improve the A1C, improve the glycemic variability? So maybe the study's too new and the ADA guidelines will change. I doubt it, but we'll see. But the data so far shows that glycemia is highly dependent on dietary carbohydrates. So we have a case series from our office, and I'm going to show you some of that data. We're going to demonstrate, we're going to seek to publish 3 patients who had severe diabetes, an average A1C of 11.9, on insulin, on metformin, on other medications, and in only 4 months of treatment here in our office using a ketogenic diet and intermittent fasting, their average weight loss was 8.7 pounds. And we selected these patients because they didn't lose much weight. They were actually on the lower end of a typical weight loss for our practice. But what we saw with their blood sugars in these severe diabetics was amazing. And here's an example of one of these patients. He started with a A1C of 12, and within 4 months, the A1C was 6.5. Now, mind you, this patient was on multiple medications. So not only did they stop their medications, including metformin, but they dropped their A1C by 5.5 points just by lowering carbohydrates, nothing else. And if you look, here's an example of the blood sugars. This is what a continuous glucose monitor report looks like. And you can see when this patient started, his average blood glucose was around 250, and it was very variable all throughout the day. And then what happens 4 months later? Consistently in a normal range, consistently in a range of about 120 to 130. And if you did, and this is just with carbohydrate restriction with a minimal weight loss, right? So this is a summary basically of our upcoming case report, and this is preliminary data. This is not peer reviewed yet, but we will submit it. We have 3 patients, an average reduction of A1C of 5.2, stopping all medications, with an average weight loss of 8.7, a measly 8.7 pounds. I mean, this is like nothing, right? And we're basically calling into question the role of weight reduction in the management of diabetes. And we're also calling into question this idea that we need to promote, lentils, whole grains, fruits to improve A1C. In this case, we promoted meat and eggs, and it seemed to do the trick much more potently than the ADA's current approach. So let's go back to our guideline checklist. We've tackled eating disorders. We've tackled severe hypertriglyceridemia. Those are published. We will seek to publish the effects of this approach on glycemia and diabetes reversal, and look out for that. So that's coming up. And the last one is lipid management and LDL. So, and this is going to be a contentious case series when it comes out, but we will certainly welcome the comments and the criticism. So LDL, what do the guidelines say? Okay, so what do the guidelines say about LDL and lipid management? Well, so I went through the ACC and AHA guidelines on the primary prevention with the idea here that I wanted to find out exactly what is their take. And they said that just like those ADA guidelines, that all adults should eat more vegetables, fruits, whole grains, lean vegetables, and minimize the intake of red meat and processed meat, and that for adults with obesity, that caloric restriction was needed. Caloric restriction, okay? So if you notice, just like the ADA guidelines, this is a biased recommendation that favors higher carbohydrates. Let's dig in deeper. Okay, if you have a high risk of an atherosclerotic event, if your 10-year risk is elevated, or if you have diabetes, or if your LDL is above 190 and they don't look at what the cause is, just above 190, okay, you should go on a statin as the first line. And I find this to be something that needs much more flexibility. And I'll discuss why. So let's give some clinical data and some clinical background just so you understand. The average LDL reduction on a statin could be anywhere from 30 to 80 milligrams per deciliter. On a PCSK9 inhibitor, which is then injectable, it could be anywhere from 50 to 150 or higher. So this is the efficacy of the medications we have. These are the medications they want us to use in the primary prevention. And there's reasons for that. There's some data to support it. I'd say the data is fairly weak, but there is data to support it. The WASCOPS trial was a study that looked at mortality after statin use, and there was a trend towards a decrease in mortality. So there's reasons why they're in the guidelines. Okay, certainly LDL and cardiovascular mortality share linear relationships. Not all cause mortality, but cardiovascular mortality has a linear relationship with LDL. So let's take our case series, and again, this is not peer-reviewed, but we will submit it for peer review. It's 5 to 7 patients with severe hyperlipidemia. They came to our practice with an average LDL of greater than 350, and they came to our practice specifically wanting a non-pharmacologic treatment option. We monitor for this, we track this, we look for this so it doesn't go sky high, that LDL doesn't go sky high. So, but these, that's the beauty of working with the medical weight loss program. We can test these labs and give you the results in 5 minutes. But these patients came to us because their doctors said that they have to go on an injectable right away, and they have a genetic issue. And they came to us seeking a more thorough and potentially a non-pharmacologic treatment option. So we did our due diligence. The first thing we did, we got all these patients' lab work from dating back to childhood in some cases. We got their family members' lab work. We sent them for genetic testing in some cases. And we have yet to find one case of familial hypercholesterolemia, meaning this is not a known genetic issue that's causing this. So what was our invention? Well, our intervention to help these people achieve their goals was not to decrease saturated fat, and it certainly was not to decrease weight, like you just saw in the AHA-ACC guidelines. And here's an example case. We had a patient come to our practice with actually, you see that their LDL here was 575, but there was one measurement that came before this where their LDL was above 700. In fact, it was incalculably high, so high that the lab came to us and said, we can't calculate it. And the patient was adamant that he didn't want a pharmacologic intervention. He went to a cardiologist who had a heart attack, and his primary care doctor who had a heart attack. And so what do? We found this patient's old data. We saw that he wasn't always this way. We asked him about his diet and how his diet changed and how his weight changed. And we made a recommendation that he very modestly increase his carbohydrate. And we told him that we cannot just let him go willy-nilly, that we need to monitor him very closely, make sure this goes in the way we want. And so we were able to lower his LDL from above 700 to 575 to 440 to the 200s, all the way down to under 189. And I'm going to highlight this 189 number because I want you to understand, once he crossed that 189 number, he no longer qualifies for meeting the above 190, which is stated by the ACC and AHA as the recommendation to treat with a statin. So very recently he crossed under 190 and is now 189. And you may not appreciate really what's going on here. Remember, I told you those statin drugs can lower it about 50 points. The injectables maybe 100 points. We have shown here a 400-point drop in LDL with dietary modification. Okay, this has not been published before. Nothing like this has ever been published before. And these patients remained ketogenic. They produced ketones. Okay, and if you'll see, he's pretty much maintained his HDL. His HDL stayed very high. His triglycerides all throughout stayed very low. And I presented these to my cardiologist colleagues. I talked to several of the cardiologists, and none showed interest. They were like, okay, they're okay. They weren't interested. Why didn't you use a statin? They asked me. So we're going to publish this case series of 5 or potentially 7 patients who've exhibited a similar behavior, the same exact behavior, LDL reduction in the hundreds, without pharmacotherapy, with diet alone, just understanding the physiology and understanding what is driving this. So here's our checklist. We've published the findings in eating disorder. We've published findings in severe hypertriglyceridemia. We will publish findings in glycemia, A1C reduction of about 6 off of all medications in 4 months, with the emphasis of meat, fish, chicken, and eggs, and a low carbohydrate diet combined with intermittent fasting. And here we show a patient, an example patient, but we'll have a case series published where we're demonstrating massive LDL reductions in the hundreds, more potent than any medication we have, using dietary interventions. In this case, we didn't decrease saturated fat, we didn't decrease their fat at all, and we certainly didn't tell them to lose weight, right? And all we did was a modest carbohydrate reintroduction with some profound impacts on their blood lipids. And if anybody's followed Dave Feldman, they could have guessed this outcome. They would have known this outcome. And the only people who wouldn't have known this were people who were not interested or were too busy to express their curiosity. Interestingly enough, the cardiologists we talked to were all unimpressed and not interested, and more concerned with why we didn't prescribe a statin. And the reason why is simple: the patients didn't want it. So I want to end off here with questions and ways to reach out to me. This is our office number. You can text us if you need help with weight loss, need help with your blood sugar, your A1C, your lipids. You can text our office and get started. On social media, I'm at Dr. Tro, and my website is drtro.com. And thank you for bearing with me. And I hope you sense the theme here that we are in this office here. I am interested in exploring the power of diet and the ability with dietary modifications to make huge outcomes in the lives of our patients. And all the dogma that we've heard that ketogenic diets cause eating disorders, that restrictive dieting and fasting causes eating disorders, well, those are all not necessarily true. If they told you that you can't do a low carbohydrate diet in severe hypertriglyceridemia, well, maybe that's not true. That all of the A1C reduction in diabetes comes from weight loss, and caloric restriction. Well, we're going to show that that's not necessarily true, and certainly we're going to show that LDL can be massively reduced without statin therapy and without pharmacotherapy at all, and certainly not with reducing saturated fat. So this is my mission to make sure that we include this knowledge into medical literature, and I thank you for bearing with me, and I'm open to hearing any questions.